Welcome to this audio recording. This is a clinical approach, a hypothetical case with questions that test the key concepts for a particular disease presentation. In this episode, I will discuss the case of a 29-year-old man with jaundice. A 29-year-old man presents with yellow discoloration of the eyes. For the past week, he has felt unwell with decreased oral intake, a low-grade fever, which he recorded at about 37.7 degrees Celsius, fatigue, anorexia, nausea, and occasional vomiting. He noticed that his eyes became yellow about 4 days ago. Since that time, he has had continuous mild pain in his right upper abdomen. His urine has also gotten darker, but there is no change in the color of his stool. He has no significant past medical history. However, he has been unable to donate blood within the past year for reasons he cannot recall. He has not traveled recently, and he works as an accountant. His only medication is ibuprofen. For his social history, he currently uses marijuana and ecstasy recreationally and has a prior history of injection drug use and cocaine. For his sexual history, he has had 5 sexual partners in the past 6 months. He does not consistently use a condom. On physical exam, he appears ill and has obvious jaundice with scleral icterus. His temperature is 38 degrees Celsius, blood pressure is 110/70, heart rate is 105 beats per minute, respiratory rate is 16 breaths per minute, and room air oxygen saturation is 99%. The lung and heart are normal apart from tachycardia. The upper body of the liver is in the 6th intercostal space mid-clavicular line, and the liver span is 15 centimeters in percussion and palpable 6 centimeters below the right costal margin. The liver edge is smooth and tender to palpation. The spleen edge is non-enlarged. There are no stigmata of peripheral liver disease and no peripheral edema. These are his lab results. AST is 1,234 units per liter. ALT is 1,560 units per liter. ALP is 394. Total bilirubin is 13.4 milligrams per deciliter. Direct bilirubin is 12.2 milligrams per deciliter. INR is 2.3 and APTT is 52 seconds. These are the results of his hepatitis serology. IgM anti-hepatitis A virus negative, IgG anti-hepatitis A virus negative, IgM anti-hepatitis B coantigen positive, IgG anti-hepatitis B coantigen is negative, hepatitis B surface antigen is positive, anti-hepatitis B surface antigen is negative, hepatitis B E antigen is positive, anti-hepatitis B E antigen is negative, and anti-hepatitis C virus is positive. Question 1. What is jaundice? Jaundice is the yellowish staining of the skin, sclera, and mucous membranes by excess plasma bilirubin. It occurs when there is a marked increase in production, decreased uptake, or decreased excretion of bilirubin. Bilirubin stains all tissues, but jaundice is most intense in the face, trunk, and sclerae. The deep yellow staining of jaundice can acquire a green hue if it's long-standing. Question 2. At what concentration of conjugated bilirubin is jaundice visible? Jaundice is visible when the concentration of bilirubin exceeds 3 milligrams per deciliter or 60 micromoles per liter. Question 3. What is the earliest sign of jaundice? The earliest sign of jaundice is scleral icterus. It can also present first under the tongue, as these two organs have very superficial blood vessels. The sclerae also have a high affinity for bilirubin due to their high elastin content. Its white color also makes it easy to appreciate the yellow tinge. Question 4. Where else can jaundice be appreciated? Jaundice can also be appreciated at the mucous membranes, palms, soles, and the skin of the chest, abdomen, and legs. The sclerae, mucous membranes, palms, and soles have more bilirubin since they are less exposed to sunlight and hence have less photodegradation of bilirubin. Jaundice spreads down the body starting with the face, including the eyes and mucous membranes, then the chest, abdomen, and legs. Question 5. What are other causes of yellow skin? Yellow skin can also be caused by carotene and other rare chemicals. However, carotene does not stain the sclera. It accumulates in the skin of the forehead, around the alae nasal, and in the palms and soles. Thyroid hormone is required to convert carotene into vitamin A. Hypothyroid individuals can get carotenemia, that is yellow skin, and nyctalopia. Question 6. Describe the normal bilirubin metabolism. Hemoglobin is degraded into unconjugated bilirubin, iron, and globin. Unconjugated bilirubin circulates bound to albumin, hence it cannot be filtered by the kidneys. Unconjugated bilirubin is taken up by the liver and combined with glucuronic acid to form water-soluble conjugated bilirubin. Conjugated bilirubin is excreted into the intestines with bile. Bacterial enzymes convert conjugated bilirubin into urobilinogen. Most urobilinogen is lost in feces as tachybilin. Small amounts are reabsorbed by the intestine and re-excreted in bile, that is the enterohepatic circulation, while some is excreted in urine. Excess amounts of water-soluble conjugated bilirubin in blood is filtered by the kidneys and excreted in urine. Question 7. How is jaundice classified? Jaundice can be classified by the site of the problem or by the type of the circulating bilirubin. Classification by the site of the problem includes prehepatic jaundice, hepatocellular jaundice, and cholestatic or obstructive jaundice. Classification by the type of circulating bilirubin includes conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. Question 8. What are the causes of unconjugated hyperbilirubinemia? Unconjugated hyperbilirubinemia is caused by hemolysis, ineffective erythropoiesis, impaired hepatic uptake, impaired conjugation, physiological neonatal jaundice, or overproduction of unconjugated bilirubin. Stool and urine are normal in color since unconjugated bilirubin is bound to albumin and is water-soluble. Question 9. What are the causes of conjugated hyperbilirubinemia? Conjugated hyperbilirubinemia is caused by hepatocellular dysfunction and cholestasis. Pale stool and dark urine are characteristic of conjugated hyperbilirubinemia. Conjugated bilirubin is water-soluble and is excreted in urine, making it dark yellow to brown. Shaking the specimen produces yellow foam because bile salts lower the surface tension of water. Feces become pale as less conjugated bilirubin enters the gut. It can result in intractable pruritus when severe, which is best treated by relieving the obstruction. Question 10. What are the differentials for dark-colored urine? The differentials for dark-colored urine include biliary obstruction, hemolysis, hematuria, rhabdomyolysis, dehydration, and certain drugs. Question 11. What are the causes of severe anorexia? Severe anorexia can be caused by hepatitis, carcinoma of the liver and stomach, pulmonary tuberculosis, chronic renal failure, and drugs such as chloroquine, metronidazole, and antibiotics. Question 12. What are the causes of non-colicky right hypochondriac pain? By anatomical structures, hepatic causes include hepatitis, an amoebic liver abscess, Budd-Chiari syndrome, and congestive heart failure. Gallbladder causes include acute cholecystitis from the duodenum, can be due to a duodenal ulcer. Diaphragmatic causes include pleuritis, right lower lobe pneumonia or pneumonitis, and a subdiaphragmatic abscess. Question 13. What symptoms are associated with complicated liver disease? Some symptoms associated with complicated liver disease include altered consciousness, drowsiness, and tremors due to hepatic failure, abnormal bleeding, purpura and petechia due to bleeding disorder or leukemia, oliguria due to hepatorenal syndrome, abdominal distension due to ascites, hematemesis and melena due to portal hypertension, sudden abdominal pain, high fever, and abdominal distension due to spontaneous bacterial peritonitis. Question 14. What further questions are important to ask in the medical and social history of a patient who presents with jaundice? Some important things to ask in the history of a patient who presents with jaundice include blood transfusion, travel history, sexual activity, contacts with jaundice, family history of jaundice, alcohol use, recreational drug use, intravenous drug use, and all medications that the patient is taking. You can use these 4 questions to help you remember what to ask. Where have you been? Where are you going? Who are you with? And what are you taking? Question 15. What clues in this patient's history point towards acute viral hepatitis? Clues in this patient's history which point towards acute viral hepatitis include an acute onset of prodromal symptoms, that is fever, anorexia, nausea and vomiting, followed by jaundice and right upper quadrant abdominal pain. This patient also has a prior history of intravenous drug use, illicit drug use, and unprotected sexual contact. Prodromal symptoms usually precede jaundice by a few days to 2 weeks. Once jaundice develops, the prodromal symptoms often regress. Ecstasy is also a rare cause of acute hepatitis. Question 16. Which hepatitis virus can cause both acute and chronic hepatitis? Hepatitis B virus can cause both acute and chronic hepatitis. Hepatitis A virus only causes acute hepatitis. Hepatitis C virus causes chronic hepatitis only. Hepatitis D virus causes chronic hepatitis but requires hepatitis B virus. And hepatitis E virus causes acute hepatitis only. Question 17. For what reason could this patient have been denied the opportunity to donate blood? There are various possible reasons that this patient could have been denied the opportunity to donate blood. These include tattoos, a history of injection drug use, or even anemia from other causes. This patient may have also tested positive for infectious disease, including either one of the following: a positive HIV test, hepatitis B surface antigen, hepatitis B core antibody, hepatitis C virus antibody, hepatitis B virus DNA, hepatitis C virus RNA, syphilis serology, and antibodies for trypanosoma cruzi. Question 18. What infections are travelers at risk of? Travelers are at risk of hepatitis A, malaria, typhoid fever, gastroenteritis, travelers' diarrhea, amoebiasis, and giardiasis. Hepatitis A is endemic in Africa and South America. Question 19. What drugs are known to cause jaundice? Antimalarials such as dapsone cause jaundice through hemolysis. Paracetamol overdose, anti-TBs such as isoniazid, rifampicin, pyrazinamide, monoamine oxidase inhibitors, sodium valproate, halothane, and statins cause jaundice through hepatitis. Flucloxacillin, quamoxiclav, nitrofurantoin, steroids, sulfonylurea, chlorpromazine, and chlorpromazine cause jaundice through cholestasis. Question 20. What transmissible infections can illicit drug use predispose to? Illicit drug use can predispose to hepatitis B and C infection and HIV. Other infections include skin and soft tissue infections, septic pulmonary emboli, infected deep venous thrombosis, and endocarditis. Question 21. What are some causes of acute hepatitis? Causes of acute hepatitis include viral causes, toxic causes, autoimmune causes, exposures such as alcohol, ischemia, and pregnancy. Question 22. What is latent jaundice? Latent jaundice is when there is no scleral icterus despite a serum bilirubin between 1 to 2 milligrams. Question 23. What are the peripheral stigmata of liver failure? The peripheral stigmata of liver failure include jaundice, gynecomastia, spider nevi, palmar erythema, loss of pubic hair and axillary hair, testicular atrophy, flapping tremors, altered consciousness, and Dupuytren's contracture. Question 24. Why is the liver tender in acute hepatitis? Inflammation causes stretching of Glisson's capsule, which causes pain in the right upper quadrant. Question 25. What are some causes of tender hepatomegaly? Some causes of tender hepatomegaly include hepatitis, amoebic liver abscess, bacterial abscess, cholangitis, congestive heart failure, and a fast-growing hepatoma. Non-tender hepatomegaly can be caused by malaria, schistosomiasis, typhoid, tuberculosis, hydatid cyst, fatty liver, malignancy, lymphoma, leukemia, and hydatid cysts. Question 26. What is a liver span? How is it measured and what is its normal value? The liver span is the distance between the upper and lower border of the liver in the mid-clavicular line. It is measured by percussion downwards from the second rib in the mid-clavicular line. The upper border is detected as dullness and the lower border is detected as a shift from dullness to normal abdominal tympany and confirmed by palpation. The normal liver span is 8 to 12 centimeters. Question 27. What are the differentials for hepatomegaly with jaundice? Differentials for hepatomegaly with jaundice include hepatitis, liver abscess, obstructive jaundice, hemolytic anemia, storage disorder, and liver malignancy. Question 28. What investigations are needed for this patient? Investigations that are needed for this patient include a liver function test and coagulation panel, viral hepatitis serology to confirm the etiology, complete blood count for leukocytosis, electrolytes, and HIV testing given his risk factors. Question 29. Interpret these results. This patient most likely has acute viral hepatitis with notable liver injury and disruption of synthetic function. There is significantly elevated AST and ALP. His ALP is more than AST with an AST-ALP ratio of 0.79, which points towards acute viral hepatitis. His total bilirubin and direct bilirubin are elevated, with a major fraction of the elevated bilirubin being direct or conjugated bilirubin. He also has an elevated INR and APTT. Question 30. What parameters in liver function testing reflect the degree of hepatocyte damage? Parameters that reflect the degree of hepatocyte damage include AST and ALT. Question 31. What parameters in liver function testing reflect the detoxification and excretory function of the liver? Parameters that reflect the detoxification and excretory function of the liver include total serum bilirubin, direct bilirubin, and indirect bilirubin. Question 32. What parameters in liver function testing reflect cholestasis? Parameters that reflect cholestasis include ALP, 5' nucleotidase, and GGT. Question 33. What parameters in liver function testing reflect the synthetic function of the liver? Parameters that reflect the synthetic function of the liver include albumin, total protein, prothrombin time, or INR. Question 34. What is the normal ratio of AST to ALT? The normal ratio of AST to ALT is 0.7 to 1.4. Question 35. What ratio of AST to ALT is seen in alcoholic hepatitis and viral hepatitis? Alcoholic hepatitis has an AST-ALT ratio of more than 2.0, while acute viral hepatitis has an AST to ALT ratio of less than 1. Question 36. What is needed to make the diagnosis of chronic hepatitis? A persistently elevated ALT and AST beyond 6 months is needed to make the diagnosis of chronic hepatitis. Question 37. What lab parameters reflects the severity of damage in acute hepatitis? Prolongation of the prothrombin time or INR reflect the severity of damage in acute hepatitis. Question 38. What is the interpretation of a positive anti-hepatitis A virus IgM? The interpretation of a positive anti-hepatitis A virus IgM is acute hepatitis A. Question 39. What is the interpretation of a positive anti-hepatitis C virus IgM? A positive anti-hepatitis C virus IgM represents acute hepatitis C. Question 40. What is the interpretation of a positive anti-hepatitis C virus IgG? A positive anti-hepatitis C virus IgG represents chronic hepatitis C. Question 41. Which serological marker for hepatitis B virus is the first to become abnormal during infection? Hepatitis B surface antigen is the first serological marker to become abnormal during infection. Question 42. Which serological marker for hepatitis B virus indicates high infectivity? Hepatitis B E antigen reflects high infectivity. It reflects the activity of hepatitis B virus DNA polymerase, hence represents viral load. Question 43. What does a positive anti-hepatitis B surface antigen imply? A positive anti-hepatitis B surface antigen may imply recent infection or previous vaccination. In recent infection, anti-hepatitis B core antigen is also positive, while in previous vaccination, anti-hepatitis B core antigen is negative. Question 44. What does a persistently elevated hepatitis B surface antigen and anti-hepatitis B core antigen IgG imply? This implies chronic infection. Question 45. How can the serological markers for hepatitis B be interpreted? Hepatitis B virus serology is complex. Please visit hyperexcision.com to see the table that explains the serological markers and how they can be interpreted. Question 46. What is this patient's diagnosis? This patient has acute hepatitis B. The illness is of acute onset with prodromal symptoms preceding the onset of jaundice by 1 to 2 weeks. He also has risk factors for infection with the hepatitis B virus, including intravenous drug use and unprotected sexual contact. There is obvious icterus with an enlarged and tender liver. ALT and AST are elevated, with ALP increased to a lesser degree. There is hyperbilirubinemia with primarily an increase in conjugated bilirubin. The core IgM, surface antigen, and E antigen for hepatitis B are all elevated, indicating acute infection. Question 47. What suggests that this patient also has chronic hepatitis C? This patient has a positive hepatitis C antibody. There is also a possibility he might have a chronic infection with hepatitis C virus given the history of being previously rejected to donate blood. He also has a history of intravenous drug use and unprotected sex, which are risk factors for hepatitis C. 85% of individuals develop silent chronic infection with hepatitis C virus. Question 48. Why does this patient not have hepatitis A? The hepatitis A IgM is not elevated. Hepatitis A IgM is elevated in acute infection with hepatitis A. Note that this patient has also not been vaccinated against hepatitis A, since hepatitis A IgG is negative. Question 49. Apart from the hepatitis viruses, what are other infective causes of hepatitis? Other infective causes of hepatitis include EBV, CMV, leptospirosis, malaria, Q fever, syphilis, and yellow fever. Question 50. Which further investigations can be used to tell the severity of liver damage? A liver biopsy or elastography can be used to further determine the severity of liver damage. Question 51. What is the best approach to treating acute hepatitis B? Only supportive treatment is recommended in the acute phase. This includes supporting liver function and monitoring for liver failure, which occurs in only less than 1% of patients. The patient is also advised to avoid alcohol, and elective surgery is also avoided since it can lead to postoperative liver failure. The sexual contacts also need to be traced and immunized. Liver function is monitored in the long term using ALT and AST, and hepatocellular carcinoma is monitored through ultrasound. Monotherapy can be started at 6 months if the surface antigen remains positive. There is no specific treatment in the acute phase since 99% recover without assistance. Question 52. Which patients are referred for antiviral treatment for hepatitis B? Patients who are referred for antiviral treatment for hepatitis B include chronic hepatitis B, chronic liver inflammation with an ALT of more than 30 international units per liter, patients with cirrhosis, and a hepatitis B virus DNA of more than 2,000 international units per milliliter. Question 53. What antiviral agents are used as monotherapy for treating hepatitis B? Agents used for monotherapy include tenofovir, lamivudine, adefovir, or entecavir. Question 54. When can interferon be used to treat hepatitis B? Interferon can be used in patients with low viral load and elevated transaminases. It works by augmenting the immune system. Question 55. What is the contraindication to using interferon to treat hepatitis B? Interferon is contraindicated when there is cirrhosis since it may precipitate liver failure. Question 56. In what situation is monotherapy for hepatitis B avoided? Monotherapy for hepatitis B is avoided in patients who are co-infected with HIV. This is to prevent HIV antiviral drug resistance. Specialist treatment with a combination of antivirals is recommended. Question 57. What is the best approach to treating chronic hepatitis C? First, genotyping is performed. Genotype 1 is much easier to treat than genotype 2 and 3, and genotype 4, 5, and 6 are more common in lower income countries. Combination therapy is done, and long-term monitoring of hepatitis C virus RNA can be used to monitor response to treatment. In case of acute hepatitis C infection, the viral load is monitored from diagnosis and continued for 12 weeks. Treatment can be discontinued at 12 weeks if the patient recovers. If the infection turns chronic, treatment is continued indefinitely. Recovery is uncommon in acute hepatitis C, and progression to chronic hepatitis is the rule. Question 58. What is the definitive cure for chronic hepatitis? The definitive cure for chronic hepatitis is liver transplant. Question 59. What is the treatment of hepatitis A? Hepatitis A is self-limiting. Supportive treatment can be done, however, the vaccine can also help. Interferon alpha, which is rarely needed, can be used for fulminant hepatitis. Question 60. In general, what measures can help prevent acute hepatitis? Measures that can help prevent acute hepatitis include hygiene, safe sex practices, vaccination against hepatitis A and B, and precautions in handling bodily fluids and lab equipment. Question 61. Which viruses causing acute hepatitis have vaccines been developed against? Vaccines have been developed against hepatitis A and hepatitis B virus. Hepatitis A virus vaccine is given to individuals with risk factors such as travelers, people living in crowded areas, and people who practice oral anal sexual contact. Hepatitis B virus vaccine is given to everyone. Question 62. What is the cutoff weight for newborns to receive hepatitis B vaccine? The cutoff weight is 2 kilograms. This is the only exception to the rule that preterm infants should receive vaccines according to their chronological age. In Kenya, it is routinely given as part of the pentavalent vaccine at 6, 10, and 14 weeks. Question 63. How many doses are needed to vaccinate against hepatitis A and hepatitis B? 2 doses are needed for hepatitis A, while 3 doses are needed for hepatitis B. Question 64. If a child is lost to follow-up before completing their hepatitis A or hepatitis B immunization, do they need to restart the series? No, they should not restart the series. They should just pick up from where they left off. Question 65. What is the recommended treatment for a newborn of a mother with active hepatitis B? The recommended treatment for a newborn of a mother with active hepatitis B is hepatitis B immune globulin, followed by hepatitis B vaccine at birth. Question 66. Can a woman with chronic hepatitis C infection breastfeed? The answer is yes, as long as there is no active bleeding from the nipples. Question 67. What precautions can be taken by travelers to protect against hepatitis A? Precautions include drinking only boiled water or bottled mineral water. Pre-exposure prophylaxis can be given 2 weeks before travel to an endemic area. Pre-exposure prophylaxis includes a booster dose. For patients who are previously unvaccinated, the vaccine can be given as soon as travel is considered, then the second dose completed according to routine. Question 68. What is the post-exposure prophylaxis for hepatitis A virus? Post-exposure prophylaxis for hepatitis A virus includes hepatitis A virus immune globulin and hepatitis A virus vaccine within 2 weeks of exposure. Hepatitis A virus immune globulin can be given if they are immunocompromised or have chronic liver disease. Question 69. What is the post-exposure prophylaxis for hepatitis B virus? The post-exposure prophylaxis for hepatitis B virus is hepatitis B virus immune globulin and hepatitis B virus vaccine. This is what is typically given to children who are born to mothers with chronic hepatitis B. Question 70. What are the complications of hepatitis B? Complications of hepatitis B include fulminant hepatic failure, cirrhosis, hepatocellular carcinoma, cholangiocarcinoma, cryoglobulinemia, membranous nephropathy, and polyarteritis nodosa. Question 71. What are the complications of hepatitis C? Complications of hepatitis C include glomerulonephritis, cryoglobulinemia, thyroiditis, autoimmune hepatitis, polyarteritis nodosa, polymyositis, and porphyria cutaneatada. Question 72. How does co-infection with hepatitis D virus change the progression to cirrhosis? Co-infection with hepatitis D virus accelerates the progression to cirrhosis. Hepatitis D virus requires a protein that is coded by the hepatitis B virus genome for its assembly. It is transmitted the same way as hepatitis B virus. Question 73. How does hepatitis C virus change the risk of progression to alcoholic liver disease in alcoholics? Hepatitis C virus increases the risk of progression to alcoholic liver disease in alcoholics. That's it for today. If this was helpful, you can find illustrations, questions, and more on this topic at hypothetical.com. See you next time.